Welcome, everyone. I'm grateful to have you all join us for our fourth and final installment of our grand rounds for 2020. Even through the uncertainty of this past year, our team has continued to work together in our clinics and our labs, and I'm appreciative of their resilience and commitment to our patients, families, and community. And based on the success of these virtual sessions, we're going to reload these monthly sessions through May of next year. Pretty soon we'll have our 2021 programming out and look forward to hosting all of you through the new year. I wanted to recognize the important work that has gone into building and promoting these sessions, from Beacon to the AUA to our colleagues running the Women's Bladder Cancer Program at Sibley. It does, in fact, take a village, and I'm especially grateful to Stephanie Cooper Greenberg for her energy and guidance has been at the center of the success of these sessions. Thank you all. So today I wanted to welcome Dr. Phil Pierorazio. So Drs. Pierorazio and Jeannie Hoffman-Sensis have been building an incredibly unique program in upper tract urothelial cancer, growing rapidly. Dr. Pierorazio completed his medical degree at Columbia and then came to the Brady for his residency training, where he's stayed ever since. He is currently an associate professor of urology and oncology. And with that, Phil, take it away.
David, thank you very much for inviting me. It's a real pleasure to talk to you and talk to our colleagues from all over and share some of our thoughts and insights about upper tract urothelial cancer. So I'm going to go ahead and share my presentation that we'll walk through here. And please let me know if there's any issue kind of seeing the slides. I kind of call this talk Understanding Upper Tract Urothelial Cancer. And as many of you know, upper tract urothelial cancer is a relatively rare form of urothelial cancer or bladder cancer. And it has a couple of unique challenges. And so over the last few months, one of the things that I've been working on is kind of mindfulness and wellness and kind of being aware of myself and how we kind of function in the world. And one of the terms that comes to mind is dharma. And when thinking of upper tract urothelial cancer, this is a disease where dharma really plays in and is really important. And what dharma refers to, if you're not aware, it's when kind of one's passion and expertise meets with usefulness and comes with a really kind of potentially life direction or at least one of our directions in medicine. But an important part of that too is that there's competence and character when dealing with this disease. Competence meaning the things we do well, and character meaning the things that are really challenging and character building. And this disease has both competence and character building components that we're going to walk through today. So we have four objectives in this relatively short talk. And the first is to talk about differences between low and high grade upper tract urothelial cancer and how we manage them differently. We're going to talk about endoscopic management, new chemoablative strategies. We'll talk about perioperative chemotherapies, how we use them in the upper tract in a different fashion than we use them in the bladder or the lower tract. And then lastly, we're going to talk really briefly about Lynch syndrome. And this is a genetic or hereditary condition that is really important for our patients with upper tract disease. So we're going to start with basics here. And I think this is a really good way to frame the upper tract talk is to think about some of the distinctions between upper tract disease and urothelial cancer of the bladder. Most of us know bladder cancer really well, so it kind of serves as a good framework and a place to start our foundation. So first of all, upper tract urothelial cancer is really rare. I call it the 5% cancer when we're talking to our medical students and residents, meaning 5% of urothelial cancers happen in the upper tract, 5% of kidney cancers are renal pelvis tumors of urothelial origin rather than renal cell carcinoma. Second, because of the ureter and the anatomic challenges, these tumors are more difficult to visualize and treat endoscopically. And while these tumors look the same, they're morphologically similar. Bladder tumors and upper tract tumors look alike. They have distinct embryologic origins. We'll talk briefly about some of the genetic differences and some of their different clinical features. For instance, in upper tract urothelial cancer, we see much more high-grade tumors than we do in the bladder. In the bladder, there are a number of rare variant subtypes, things like sarcomatoid tumors or squamous cell cancers. These are really rare in the upper tract. And we have known causative factors, particularly Lynch syndrome, which we will talk about, but also environmental exposures that lead to upper tract urothelial cancers as opposed to bladder cancers. And just to kind of touch on the genetics, we see similar but different mutations in the upper tract. We see FGFR3 mutations, which are really common in low-grade bladder tumors, also common in the upper tract. We also see P53 mutations in high-grade cancers, which are also really common in the bladder. But we also see differences in chromatin modifying genes. These are genes that can affect the body's ability to repair from DNA damage. And all of these genetic data say that there's likely a more common progression from low to high grade tumors in the upper tract than there are in the bladder. Another interesting study, this was done from our colleagues in Memorial Sloan Kettering. They looked at bladder cancers and upper tract urothelial cancers, almost over 600 patients with both tumors. And what they found is while the genetic defects were really similar in bladder cancers and upper tract tumors, kind of the patterns were different, where you had much more of those FGFR3 mutations in upper tract disease and much more P53 mutations in bladder cancers. And importantly, we also found that a lot of these tumors were clonally related, meaning a lot of patients have both upper tract and bladder cancers. And if you look at the genetics, about 86% of those tumors share mutations, meaning they come from kind of the same genetic defect. So, fourth clinical distinction between bladder and upper tract disease is staging and grading. So like bladder cancer, stage or the depth that these tumors invade are one of the most important prognostic factors. But unlike bladder cancers, grade is much more highly correlated to stage. So in the bladder, we see a lot of high-grade non-invasive tumors. That's not really true in the upper tract. We see anywhere from 60 to 90% of high-grade tumors in the upper tract are invasive. You even see invasive cancers with carcinoma in situ or flat cancers in the upper tract. We typically don't see those in the bladder. The prognosis is also different. About 20% of patients with upper tract disease present with metastatic disease. And for that reason, you see higher rates of progression and death for patients with these upper tract tumors. Interestingly, if you look at kind of large data sets, what you see is that progression-free and cancer survivals are worse for the renal pelvis tumors, but there's really no difference in stage-specific survival. Meaning, if you have a TA tumor, it's the same whether you're a bladder cancer or your upper tract urothelial cancer. For the invasive tumors, it's about the same, but many more patients with upper tract disease present with those advanced stage tumors earlier in their diagnosis. And lastly, we know a lot about neoadjuvant and adjuvant chemotherapy in bladder cancer. It's not as well established in the management of upper tract disease, something Dr. Hoffman-Sensis and myself and our team are working to change. So here's just kind of some of our general management principles for this disease. So first, I told you it's relatively rare. It's only about 5,000 cases per year in the US. This is a disease of the elderly, so on average 70 to 90 years old. We already talked about some of the risk factors. So tobacco use is shared with bladder cancers, but there are a number of environmental exposures and Lynch syndrome leading to a ratio of about 3 to 1 in men to women. The treatments are highly variable. Radical nephroureterectomy refers to surgical removal of the kidney and the ureter. That is kind of the most common and standard approach, but we do have organ-sparing options, which is really a growing and unmet need for a lot of our patients. The recurrence rates are really high, even after surgical removal of a kidney and ureter. Most of those recurrences happen in the bladder or the urinary tract, but they certainly can happen systemically or outside as well. And survival rates strongly depend on the stage of diagnosis. The survival is excellent for people with low stage, low grade disease, but it is really poor in the case of patients with distant metastatic disease. Those numbers are changing now with better systemic therapies, but still a really challenging disease in the metastatic setting. And when we think about how we break these patients down and how we think about how to treat them, it's really based on grade. Low-grade tumors are slow-growing, unlikely to spread around the body. They certainly can spread in the urinary tract. And so we think about kidney-sparing treatments, where high-grade tumors are really rapidly growing, high risk for local invasion, metastatic progression. And we really consider this a systemic disease where we're talking about surgery now and chemotherapy as our option. So the European Association breaks down low-risk and high-risk patients with upper tract urothelial cancer. And you'll see a whole bunch of clinical characteristics. Most of that, I'll tell you, is driven by grade. So low-grade tumors in general are low risk. High-grade tumors in general are high risk. And when we think about the management paradigms, kidney-sparing approaches are an option for patients with low-risk, low-grade disease, while once again, we really consider high-risk, high-grade disease a systemic disease with the need for radical surgery with or without chemotherapy. So to kind of summarize our basics, we know bladder and upper tract cancers are related but different. Genomic differences can explain a lot of the distinctions in our clinical features. And risk stratification really shifts our management, and it's based on histologic grade, low versus high grade. So we're coming into the winter and ski season. Who knows what ski season will be like this year? But this is one of my favorite mountains. This is Snowmass in Aspen. It's a great broad mountain with a lot of breadth, and I think it offers, the ski mountain offers a great metaphor for understanding our upper tract urothelial cancers. So when we start with low grade or low risk disease, we're really talking about our green and blue trails. So if you look at our ski map again here, your green and blue trails are broad. There's lots of ways to get to the bottom of the mountain, and very rarely are you going to run into a single or double black diamond where you're going to get yourself or that patient into trouble. So when we think about our management principles for low risk or low grade disease, first is we want to treat that primary tumor. We got to get rid of the cancer that we can see. Second, we know these tumors are likely to recur most commonly in the urinary tract, so let's manage those recurrences and recognize that these patients have a minimal risk of progressing to high grade or metastatic disease. So how do we manage them? Well, in this setting, a radical nephroureterectomy is the gold standard, but I say it's the gold standard and last resort. We really only try to remove kidneys where we have no other options available to us. So what are the kidney sparing surgeries? Well, we can do endoscopic management, meaning cameras and instruments inside the urinary tract. We can add topical therapies like BCG or mitomycin, and there's new chemoablative strategies, basically using topical chemotherapies to ablate or destroy tumors in sight. So, important, I told you radical nephroureterectomy is the gold standard, but last resort. However, if you look at population-based data, 70% of patients in the US are still undergoing a nephroureterectomy for low-grade, low-risk disease, even though their 5-year survival is almost identical to patients who undergo endoscopic or kidney-sparing management. Why is nephew a bad idea in this population? And it's not a bad idea, but why are there risks to it? Well, I told you, it's often an elderly population, 70 to 90 years old. That population has a risk of morbidity and complications as related to surgery. I'll tell you, removing a kidney is relatively straightforward, but anesthesia, being in the operating room, all adds significant risks to a population that may not need their kidney out. Once again, older populations tend to have a risk for kidney disease, and what you see is removing a kidney puts patients closer to end-stage renal disease and dialysis. And with worsening kidney function comes increasing risk of cardiovascular disease and events. So, removing a kidney is not without risk in this population. Well, what about endoscopic management? Well, we know the majority of bladder cancers are managed endoscopically, right? TURBT and BCG is kind of our mainstay therapy for bladder tumors, but the minority of upper tract tumors are managed that way. First of all, we've got some biologic differences. Second, we've got inadequate tools. The ureter is really tiny. It's about the size of a shoelace. And getting an instrument up there that can get adequate tissue and treat adequately sized tumors is really challenging. And while most of these cancers are managed by oncologists, it's our endourologists who are really good at using the instruments and tools that can get up into the kidney. So we've got inadequate training for a lot of our cancer specialists. And on the flip side, a lot of our endourologists are really good at the technology, but may not understand the intricacies or the biology of urothelial cancer. So we've got to bridge that gap. What are the issues with endoscopic management? Well, in a rare disease, it's really hard to get randomized trials. There's a lot of selection bias, meaning we pick out the patients who are going to do well and report those in the literature. There's a lot of variation in the comorbidities and the reasons we're sparing kidneys in patients. Some patients just have their tumors treated, but we don't know whether they were low or high grade. And we really only have about 3 years worth of follow-up in these patients. So we really don't know a lot of long-term data here. And here's just some of the data. I'm not going to run through the details of this, but just to show the importance here. You see that the overall mortality is not insignificant in this population, somewhere from 20 to 30%. About 10% of patients will die of upper tract urothelial cancer. 20 to 30% of them will fail endoscopic management and need a nephroureterectomy. And you see that kind of mirrors the risk of progression and metastatic disease in that population. And this is just one good study that kind of highlights how these things can be done. This was 80 patients with relatively large tumors managed by an experienced center who was able to kind of, through multiple sessions, get rid of even big upper tract tumors in patients. But you can see even in this expert center, 20% of those patients went on to have their kidney removed and 15% of patients died of cancer. What about topical therapies like BCG or mitomycin? Well, there's some challenges here. It's really hard, first of all, to get a drug to stay in the kidney. The kidney and the ureter are constantly making urine and forcing them out of the kidney down into the bladder. In the bladder, that's a reservoir, and these drugs are designed to sit there, or the urine sits there so we can take advantage of that. But the kidney and ureter were designed to continuously expel urine, and if we put drug up there, those drugs are continuously expelled too. So while mitomycin and BCG may work, it's hard to get those medications to sit up there. It can be really challenging for our patients and for us to get good medications up there. So recently, some new advances have been made. One of them is a product called Jelmyto, which is now FDA approved. This is a product which is liquid at room temperature, and when it's injected into the body, you'll see when it gets warm in a second, it actually solidifies, and it can be impregnated with a variety of medications. For upper tract urothelial cancer, it's impregnated with mitomycin. It sits up in the upper tract and can therefore slowly dissolve over about 4 to 6 hours and effectively ablate upper tract urothelial cancers. So this was used first as what we call a compassionate use study, just as a safety study in about 20 patients, and we found that it was effective. More recently, a larger study was conducted, over 70 patients, multiple institutions. We were one of the lead sites, along with MD Anderson in this country. And what you saw is a really effective drug. 60% of patients were effectively treated, but it led to about 40% of ureteric stenosis, or tightening of the ureter, because of the caustic nature of this medication. And we know that a lot of that can be alleviated with time and experience, but this ultimately led to the FDA approval of this drug. I'm going to skip through some of the additional data, but just once again to show, most patients experienced a treatment of their cancer within 3 months or immediately following treatment. And most of those responses were durable out to a year at least. And we're gathering long-term data from this initial study. And what you'll see, once again, about 40% of patients with ureteric stenosis or tightening of their ureter, but most of this happened at the end of treatments. There are lots of ways to alleviate this, and even giving some oral steroids sometimes can help this inflammation. And we don't think this is a necessarily game stopper for a lot of these patients. So to summarize, low-risk disease, nephroureterectomy is the gold standard and last resort. Endoscopic management is an option for well-selected patients, and we need to do a better job of marrying our endoscopic urologists with our cancer doctors to make sure we're offering optimal treatment. And we can use intracavitary therapies and chemoablative technologies to really spare kidneys and offer patients an excellent outcome here. So back to our ski analogy, and we're shifting gears now into high-grade and high-risk disease. We are much more towards the top of the mountain. We have much more treacherous terrain here, and we really have to proceed with caution to make sure we treat our patients and these cancers properly. So management principles for high-grade disease. First of all, I really consider this a systemic disease. And what does that mean? It means we have to consider nephroureterectomy as the foundation of therapy, but we also have to consider chemotherapy in our treatment paradigms, whether it's before surgery like we do in the bladder or after. So when we think about nephroureterectomy, what does that mean now? Well, it means we're really only offering those endoscopic therapies for patients who can't go to the operating room and have a kidney removed. We talk about things like surgical approach, robot, open, laparoscopic. Lymph node dissection is an important part of this disease management. How we cut that ureter out of the bladder makes a difference. How do we manage recurrences in the bladder? And lastly, how do we fold in systemic therapies, chemotherapy before and or after surgery? So just to kind of briefly touch on open surgery versus laparoscopic versus robotic. The honest answer is it really doesn't matter. Nephroureterectomy refers to radical excision of the kidney and the entire ureter down to the bladder. What really matters is that an experienced center, an experienced surgeon are doing a good job in getting the entire ureter out. Obviously, there's different recovery periods for open surgery versus laparoscopic or robotic, but what's most important is a good cancer operation, and then the recovery time becomes moot. What's also really important is that lymph node dissections happen for high-grade disease. This is data we looked over by one of our wonderful medical students who's now at UCSF. Looked at what the importance of lymph node dissection, and it has both a staging and therapeutic benefit, meaning by removing lymph nodes, even patients who did not have any lymph node positive disease, it shifts their survival curve up, meaning we're more certain that they do not have systemic disease. And in patients, even patients who had node positive disease, cancer in those lymph nodes, those patients did better if they had those cancerous lymph nodes removed. So really important for the management of high-grade disease. How do you manage the bladder cuff, or basically cut a hole in the bladder to make sure the entire ureter is removed? Once again, doesn't really matter. There's no difference in recurrence survival, cancer-specific survival, or overall survival, depending on how that's done, as long as it's done well and entirely. And then how do we manage bladder recurrences? So we use a lot of intravesical chemotherapies, meaning topical chemotherapies in the bladder now for upper tract disease. And we know that upwards of 60 to 80% of patients who have upper tract disease will develop a bladder cancer recurrence, whether that's after nephroureterectomy or even just ureteroscopy. We think that this is either due to implantation. We're stirring up those tumors. Those cells are now reimplanting in the bladder, even though they wash out of the kidney and ureter. And we know that chemotherapy is really effective for bladder cancer treatment if we put it in the bladder to reduce reimplantation. So why wouldn't it work for the upper tract? Well, I'll tell you, actually it does. And there's some really good data, but this is retrospective data saying you can take the recurrences from about 40% to 13% in retrospective studies. But there's also good randomized study. This was a study done in the UK, showing that you could reduce the rates from about 30% to 15 or 20% by putting mitomycin C in the bladder at the time of nephroureterectomy. So this is now standard of care for us. This became standard of care when we started looking at our own experience, and we saw that 45% of our patients experienced a bladder cancer recurrence within the first year after nephew if we did not put chemotherapy in their bladder. So now we consider this standard of care. What about systemic chemotherapy in the last few minutes here? So we know neoadjuvant chemotherapy or chemotherapy prior to cystectomy improves survival for patients with muscle-invasive bladder cancers. Well, what about in the upper tract? Well, we know it works for the bladder. We know upper tract urothelial cancer is biologically at least similar to urothelial cancer of the bladder. There is some retrospective data that shows neoadjuvant chemotherapy can downstage or shift upper tract urothelial cancers to the T0 state or non-invasive states. But very importantly, in the upper tract, we know many patients who undergo a nephroureterectomy will have worsening of their renal function and no longer become eligible for platinum-based chemotherapy that's filtered by the kidneys, and that could poorly affect their ability to beat this cancer. And so here's some retrospective data, both from MD Anderson and from our institution, showing that neoadjuvant chemotherapy, or the same chemotherapy you would use for the bladder when used for upper tract urothelial cancer, makes it much more likely for patients to have non-invasive disease. You'll see those curves kind of shift for the chemotherapy patients. And we don't have a lot of great data on survival benefit, but there certainly seems to be some data that says patients who get neoadjuvant chemotherapy do better than those who do not. Dr. Hoffman-Sensis, who's one of the greatest colleagues in the world, recently completed a phase 2 trial looking exactly at this question. And what you see is higher rates of complete response or no evidence of cancer after chemotherapy before surgery, and really high rates, 60% of patients had non-invasive cancers, although they had likely invasive cancers at the outset of the study. And lastly, when we talk to summarize kind of our high-risk disease here, robotic technology and robotic nephew is changing the way we think about nephew. The cost associated with that technology may be balanced by improvements in perioperative outcomes, but we do have oncologic outcomes for all, equivalent outcomes for all of our approaches, recognizing that we have to do lymph node dissection for a lot of our patients. How we manage the distal ureteral cuff is not so important as long as we get the entire ureter out. We really need to be thinking about intravesical and systemic chemotherapies around the time of surgery to reduce the risk of recurrence in the bladder and recurrence elsewhere in the body. And then lastly, I'm just going to spend the last couple of minutes talking about Lynch syndrome. So Lynch syndrome is an autosomal dominant disease, meaning you only need one gene from one of your parents to pass this syndrome down. The most common cancers associated with Lynch syndrome are colon cancers and endometrial cancers, but upper tract urothelial cancers are a really important component of this disease. And you see 6% of Lynch syndrome patients will have an upper tract urothelial cancer. That's not really high, but I told you how rare this disease is. That's upwards of 20 times higher than the risk of upper tract urothelial cancer than the general population. So we basically consider Lynch syndrome in almost all of our patients with upper tract urothelial cancer. There's really important clinical criteria for patients when you're looking or considering Lynch syndrome. These are called the Amsterdam criteria, or affectionately known as the 3-2-1 criteria. And what you're looking for is one first-degree relative that has one of these cancers, 2 successive generations, or 3 relatives with either a colon cancer, endometrial cancer, or one of these upper tract urothelial cancers. And there's a really nice algorithm put forward by our good friend and colleague, Serena Mateen at MD Anderson, that talks about how we're supposed to screen these patients. And basically, when we take their tumors out, we can screen them, or our pathology colleagues can screen them by looking for what are called DNA mismatch repair genes. I alluded to those in the beginning of this talk. If there's a DNA mismatch repair gene that can be detected by pathologists, we can then refer these patients for genetic counseling, and about 5% of patients will have a diagnosed Lynch syndrome after all this work up. So in summary of our whole talk here, genetics define our clinical discrepancies between upper tract and bladder urothelial cancers. There are divergent management pathways for low-grade, low-risk disease and high-grade, high-risk disease. Endoscopic management is in the urologist's domain, and we have a variety of tools, but we're not so great at integrating them yet. And lastly, the surgical management of our disease is evolving, but should always include consideration of perioperative systemic chemotherapies, lymph node dissections, excision of our ureteral cuffs, management of intravesical recurrences or bladder recurrences, and strong consideration of bladder therapies. And lastly, we should be considering Lynch syndrome in all of our patients with upper tract urothelial cancer and anyone with a family history of other diseases. I'd just like to give one additional slide here. Dr. Walsh, our chairman emeritus, always used to talk about the great Wayne Gretzky quote, how do you become kind of the leader in your field? Well, it's not skating where the puck is, but where the puck is going. And these are some of the things we're considering. Dr. Hoffman-Sensis and I have put in all the groundwork to start an upper tract urothelial cancer multidisciplinary clinic where patients can meet with her, myself, Dr. Nirmish Singla, who's one of our new faculty members, to meet with the entire team in the same day, in the same setting. Unfortunately, that's got derailed a little bit by COVID, but we hope to have that up and running in the spring in a physical format. Dr. Winokur, who's one of our young faculty members, is working with our technology group in the engineering department for looking for micro grippers, or these tiny little magnetic, basically, devices that can better diagnose potentially and treat upper tract urothelial cancers. Dr. McConkey's group and team, we're working on genomic predictors of neoadjuvant chemotherapy, and also growing tumor organoids, basically cancers outside of the body, so that we can test responses and treatments. And lastly, we're working on trying to improve renal function in these patients by coming up with what we call a nephron sparing protocol, using a variety of agents and treatments to keep kidneys around. And we are now open and using an FDA-approved drug, Jelmyto, to predict our patients. So lastly, I just have to give kudos to the Greenberg Bladder Cancer Institute and highlight my colleagues in upper tract urothelial cancer. Obviously, Dr. Jeannie Hoffman-Sensis, who really leads our medical oncology multidisciplinary services, Dr. Winokur, who's our endourologist extraordinaire, Dr. Nirmish Singla, who's our newest member of the urology faculty and a great urologic oncologist, and Dr. McConkey for his guidance and leadership and his collaborative spirit, where we're now doing all of these upper tract urothelial cancer translational and science studies that hopefully bring us to the forefront and really make a difference for our patients. So I will end it there and open this up for questions and discussion.
Thanks, Phil. So if anybody has, there we go, starting my video. Thanks, Wasim. So if anybody has any questions, if you could just put them in the Q&A or the chat, I'll go ahead and field them and present them to Dr. Phil. Maybe I can start out with one. So you intrigued us with this introduction of the nephron sparing approach. Can you tell us a little bit more about what that approach looks like?
Yeah, so, you know, for many patients, I told you, renal function is of paramount importance. And while upper tract urothelial cancers can be scary and life-threatening, dialysis is not without its issues as well. The median life expectancy on dialysis in the US is 5 years. Now, those are often patients with other issues that are contributing to that. But that kind of parallels the life expectancy for upper tract urothelial cancer or an advanced upper tract urothelial cancer now. So we're really trading one for the other. So the nephron sparing approach refers to the fact we're going to do everything we can to try and keep people away from end-stage renal disease and dialysis. So how do we do that? Well, it depends on the tumor, but for low-grade tumors, for instance, we can use Jelmyto, we can use lasers, and we're even thinking about using systemic therapies. There's now FGFR3 inhibitors that are available. These are you know, kind of systemic therapies that can address these localized diseases to see if we can keep kidney around and at least keep tumor in check if we can't totally eradicate it. The other option is for patients with high-grade disease or more aggressive cancers. We've seen the approval of either oral or systemic agents in high-grade bladder cancers. And now can we translate some of the systemic therapies for high-grade disease into the upper tract, once again, using a combination of endoscopic treatments and systemic therapies to try and keep kidneys around and keep people off dialysis.
Okay, we've got a question from Claire and John Pitzer. Can bladder cancer migrate to the upper tract? How do you distinguish between them? Good question.
Great question. So statistically speaking, most urothelial cancers kind of descend. So in patients whose first diagnosis is with a bladder cancer, only about 10% of them will develop an upper tract urothelial cancer. So it's not that common. It's not uncommon either. And typically where we see that is someone who has recurrent tumors in their bladder that just doesn't make any sense. It doesn't meet kind of the normal bladder cancer recurrence. We get upper tract imaging, either CT scan, MRI, or retrograde, and we find an upper tract tumor that's kind of been seeding the bladder, for lack of a better term. On the flip side, upper tract urothelial cancers are incredibly common to kind of descend or develop in the bladder. And as I said, the data shows upwards of 80% of patients with a history of upper tract disease will develop bladder cancers or bladder tumors. I basically tell all of my upper tract patients that if you live long enough, you're going to develop a tumor in your bladder. It is our job to keep an eye on that and make sure that it is not going to affect kind of your longevity or your disease progression and catch them soon. So bladder surveillance is part of the upper tract urothelial cancer management.
Thanks, Phil. So Dan would like to know, who does one reach out to for consideration for evaluation by your clinic?
Yeah, you could either reach out to myself or Dr. Hoffman Census, and usually we kind of, as I said, COVID kind of totally derailed these plans because all of a sudden our physical spaces went away, and it doesn't make a lot of sense to do this in a multidisciplinary telehealth clinic. We want to see people. We want them in the same space so we can have everybody together. So when we have that up and running will likely be the spring. If you want consideration for that, you can email me. You can email Dr. Hoffman Census or their bladdercancer@jhmi.edu. We'll also put you in touch from us. Thanks, Mike, for putting that email out there.
Okay, so from Karen Saxa, did your pteric stenosis from RT gel require nephrostomy tube placement?
Yeah, So in about 10% of those patients, they went on to a nephroureterectomy because they had some kind of permanent either stricture or scarring of their ureter. That's not a great outcome, but you could also make the argument if there wasn't something like Jelmyto or RT gel, that all of them would have had their kidneys out. So I think what we've all learned, and I treated quite a few patients on the study, and if you talk to people around the country, that most of the stenosis issues happened after treatment number 3. And whether it's inflammation from the drug, inflammation from the instrumentation, it's when you start pushing through that inflammation that you cause the kind of irreversible issues. So if you start noticing what all the clinicians are talking about now is that if you start seeing or feeling stenosis or tightening, just back off. Give that patient some time to either recover and give them more treatment, or if you've got 3 doses in, maybe stop and reevaluate them with a ureteroscopy because that treatment may be effective and may minimize the risk of complications down the road. So really untold story. My take home from that medication is we now have a highly effective topical medication for low-grade upper tract urothelial cancer. What we've got to figure out now is how to optimize efficacy and minimize risk of side effects or toxicities. And I think there's a number of smart people around the country who are going to get this figured out over the next year or 2.
So Phil from B, what are the advances in chemotherapy for upper tract cancer? Is there anything beyond Keytruda?
Yeah, so most of the upper tract urothelial cancers are treated just like bladder cancers. So platinum-based chemotherapy remains our first line or frontline therapy. So, if we've got a patient who are considering neoadjuvant, or if they've already had their kidney out and we want to consider adjuvant, it's usually platinum-based chemotherapy. So whether that's gemcitabine and cisplatin or the more recent kind of accelerated MVAC regimen, that's first-line therapy. If that's not working, then checkpoint inhibitors like Keytruda, it tends to be pembrolizumab in the upper tract because that's what's approved kind of for lower tract as well too. But pembrolizumab, atezolizumab, a variety of these now immune boosting checkpoint inhibitors are really the therapies that are considered in second line for patients who cannot receive platinum-based chemotherapy because of kidney function issues.
Yeah, and we're exploring using what Phil introduced earlier, these FGF receptor inhibitors. You've heard of the approval of erdafitinib for lower tract disease. As he pointed out, upper tract cancers have even more of the target in them. So we imagine that they might even be more, a larger fraction of patients who would respond. And then finally, Jeannie's trial that we introduced you to involves something called an antibody drug conjugate, one that maybe many of you are familiar with, called enfortumab vedotin, which has been, again, approved for lower tract disease. And in Jeannie's trial, the drug's going to be combined with pembrolizumab. So a lot going on, actually, in the development of investigational therapies for upper tract cancer. And as Phil mentioned, we're looking for new stuff, too, by doing exploratory work in these really interesting models called organoids, which we have 8 growing in the lab right now. So, okay, last call for questions. Well, Phil, I'd like to thank you for taking the time out of your busy day to do this. Always a pleasure to work with you. See you twice in one day. Had our weekly upper tract meeting this morning. And I'd like to thank all of you for attending this session, and hope you have a great holiday season. Stay healthy, be safe, wear your mask, and we'll look forward to seeing you again in the new year.